So we're going to start with a quick look at the basic structure and function of the respiratory system. So the primary function of the respiratory system is that of gaseous exchange. So that's taking oxygen in and getting carbon dioxide out. And the thing about our respiratory system, it's absolutely perfectly designed to deliver its function. What we've got here is we're just looking at a cross section of all of the airways. And do you know that from here right down to the alveoli, these airways, they split about 23 times. So by the time you get down to these tiny little tubes here, the bronchioles, these are less than a couple of millimeters in diameter. So the tiny, tiny little airways. And in asthma affects all of these respiratory airways, not just these big ones. In the early days, certainly when I started doing asthma, we thought that asthma was primarily a disease of these big upper airways. But the reason for that is we didn't really have the technology 30 odd years ago to go searching down here at the bottom. In recent years, you know, we now know things that are very different. We know that asthma in its early days may very well affect these tiny, tiny airways down at the bronchioles. Another thing about this, while we're just looking at this image, is if you think about inhalers, you know, respiratory inhalers, the drugs in the inhalers, they will only work if they get to the part of the lung where the inflammation is. So let's just suppose you've got an asthma patient, and let me just get a little pen here. Let me see if I can do a bit of drawing for you. So let's just pretend that you've got a patient and their asthma is really bad down here at the bottom. Okay, right down at the bottom there. Well, for the drug to work, it's got to get from here. It's got to get all the way down here, right the way to the bottom, so that it can start to do its magic. We're talking here about inhaled corticosteroids. We will be talking about those in a couple of videos' time. The thing is, they reckon that it takes an adult 5 seconds to breathe in from here and a big 5-second breath to pull the drug right the way down to the bottom. What you'll start to discover when you start doing asthma reviews is that one of the biggest problems in asthma is poor inhaler technique. It's exactly the same in COPD, to be honest. So we will be doing quite a bit on that. But in order to make sense of that, it always helps for you to kind of appreciate the size of the respiratory system. I mean, while we're sitting here now, if you was to grab the bottom of your ribs, because you can see the ribs here, this thing here is the diaphragm. If you grab the bottom of your ribs, it just gives you some idea of how far down the airways go. You know, there's a lot. It's a long way from here right down to the bottom. Inhaler technique is, to me, one of the most important parts of any respiratory patient review. Now, the function of these airways, all that they do is they actually just guide fresh air down to the alveoli, and then any carbon dioxide rich blood that comes to the alveoli, the carbon dioxide is diffused into that and then it's breathed out this way. So that's our wonderful respiratory system, perfectly designed to do its job. I'm going to show you a cross section of these airways in a minute so you can kind of appreciate how they work in more detail. But just to focus our attention on here, on the alveoli, I'm going to just move on. Gaseous exchange takes place here within the alveoli. So as the air, fresh oxygen-rich air, hits the alveoli, you can see the blood vessels that are wrapped around it. You've only got a cell of blood vessel and a cell of lung tissue, and it's got to be like that so that you can get very rapid gaseous exchange. So this is where it all happens. You know, air is brought to one side by the airways, and then blood is brought to the other side by the blood vessels, and that's where the gaseous exchange takes place. So what I want to do now is just to have a look in more detail at the structure of one of the respiratory airways. The thing to remember is that in diseases like asthma and COPD, this structure that I'm going to take you through, it's all disrupted. And that's where you start to get all the problems that we get with asthma and COPD. So I'm going to start on the inside. I'm going to work my way out. I'm going to walk you through all the structures that are important. And when I say important, I mean important for us to know in order for us to do a really good respiratory patient review. So let's start here. When we refer to the lumen, that's what we're referring to. When we start to look at lung function testing, and especially when we do COPD, and we start to talk about patients having a FEV1 of 50%, that's given us a clue to how obstructed this space is. So at the moment, this would be a 100% open airway. If you can imagine it being obstructed with disease so that there's only 50% of it where air can travel in and out. Okay, so on the inside, all of our airways, they're lined with these tiny, tiny little hair-like structures. They're called cilia. The function of the cilia is to constantly be wafting upwards and towards the middle. And the function is, if anything untoward lands in our airways, like a virus or a particle, maybe some pollution from outside, or bacteria, you would hope that the cilia would be able to trap it, and what they do is they waft it into here, and hopefully we could then cough it up. So it's a protection, is this. So that is the cilia, that's on the inside. If you start to get inflammation of the lungs, this becomes disrupted, and so what happens is the lungs lose it's like almost like an immune, it's protecting us, and so when that gets disrupted, that then lowers our resistance to fighting potential invaders such as bacteria and virus and pollutants. Sat just below this is the epithelium. This is so important, is this epithelium. You want this intact, because when this starts to become inflamed and broken, it exposes this part of the airway. And if you've got an asthmatic who's allergic to, I don't know, let's say pollen, if this is missing, then it makes it a lot easier for that pollen to get in there and start causing all the trouble that trigger factors do in asthma. And again, we will be learning about those as we progress on. So there's the epithelium. We've also got mucus producing goblet cells, and we do need mucus. I know it's not the most lovely of things for us to think about, but in the grand scheme of it, the mucus helps the cilia because it helps to trap virus and bacteria and pollutants. So we do need a little bit of mucus. It's just that we don't want too much of it. And what can happen in asthma is that the mucus production can be increased, and then that starts to cause an obstruction. In COPD, it's increased to quite a significant amount in some people. But the problem when you've got lots of mucus in your airways is it can attract, it's a very good vehicle for infection. So it's very good at carrying infection down to the bottom of the lungs and dropping it off in the alveoli, and that's when we get things like pneumonia. Our respiratory airways, even though their job is to take oxygen in and take carbon dioxide out, at the end of the day, this is all still living tissue. And so our airways need blood vessels to bring nutrients and oxygen, just like the rest of our body systems. So we do have blood vessels in here. One of the problems in things like allergic asthma is when people come into contact with what they're allergic to, sometimes these blood vessels can get bigger. And the problem with that is they take up more space, and that can contribute to the obstruction on the inside. The other thing that blood vessels can do is they can start to leak, and that's when we get edema. Have you ever seen people that have got hay fever? And you might see the eyes are swollen or the lips are swollen. But what you're looking at there is an external manifestation of dilating and leaking blood vessels, and that can happen in the airways as well. And sometimes people with asthma, they'll tell you that they cough up mucus, but it doesn't clear the feeling of obstruction, because it's not just the mucus that's obstructing, it's the swelling as well, the edema. I mean, you must have experienced this yourself if you've ever had a cold and your nose is blocked and you blow your nose, but the nose is still blocked because there's other things that's causing that obstruction. We've got lots of lymphatic vessels within our airways, and we've got lots of macrophages. This is your own body's these are floating about looking for pathogens so that they can gobble them up and get rid of them, just so that, you know, they don't cause infections. But one thing that asthmatics have in abundance are these things that are called mast cells. And asthmatic atopic people have got more of these in their airways than people that have not got asthma. I'm going to tell you about mast cells in more detail in a short while, so I'll leave that in peace just for now. All of this has got a fancy name, and that's what it is. You don't need to remember this at all. I'm just wanted to put it in there in case you saw it in another textbook. Wrapped around our airways, we've got smooth muscle. And this smooth muscle is under the control of the brain. And the brain sends messages to it via different receptors, and I'm going to show you that in a tiny bit more detail on its own in a short while, so I'll just leave that. In the epithelium, can you see this here? You've got what are called glucocorticoid receptors. All of the inhaled drugs that we use in asthma, for them to work, they've got to be able to attach to one of these receptors. So the receptors that inhaled steroids target as placed in the, as you can see on here, in the epithelium. On the smooth muscle, we've got what are called beta receptors, and these are what are receiving messages from the brain telling the airways to tighten up or to relax, depending on what's going on. And these are the receptors where drugs like salbutamol, the short-acting and long-acting bronchodilators, need to stick. We've also got another group of receptors that are called muscarinic receptors, and the drugs like Atrovent and ipratropium, tiotropium, they target these receptors. In some people with asthma, mainly the more severe end of asthma, these can become disrupted. These are more associated with COPD and the drugs that we use in COPD. And you also find these receptors on the mucus glands. And this is one of the reasons why people with COPD can often make lots of mucus, because of the damage that happens on these receptors when people smoke cigarettes, if you like. But again, we'll be going through all of this in more detail when we do our COPD module next. And last, but certainly not least, we've got another group of receptors called leukotriene receptors. And again, they're situated here on the smooth muscle. And the drugs that attach to these are the ones that are called, you'll maybe have heard of this, it's called Montelukast. And this is a tablet. So it's one of the tablets that we use in asthma. So that is our lovely, nice, gorgeous, normal respiratory airway. And as the air moves along the respiratory tract from the mouth, it's warmed, it's moistened, and then it's filtered. The mucus helps to moisten it. It also helps to warm and filter it as well. But the blood vessels also help with the warming, etc. The filtering happening because of the cilia and the mucus secreting glands. So that's our gross structure. I want to talk to you for a really short while about how the brain controls the diameter of the airways. It's really important because this is where some of the drugs that we use in asthma and COPD work. So as we know, the brain, it controls everything in our body, doesn't it, eh? And I'm certain that you're aware that the brain can be divided into the sympathetic nervous system, the parasympathetic nervous system. Innervated just means controlled by. Now then, if we focus on this, in order for the brain to pass messages all around the body, it needs a neurotransmitter. That's a chemical messenger that takes its messages and drops them off all over the place. The neurotransmitter, or the chemical messenger for the sympathetic nervous system, is called noradrenaline. This nervous system is sometimes referred to as the adrenergic nervous system. Okay, and that's where we get the beta-2 agonists, beta-2 adrenergic agonists. That's where you start to get all the drug names, and they all start to make sense. An agonist enhances the action of something. Okay, so in this situation, an agonist, and I'm just going to get my little pen again, and you might see it abbreviated as SABA, short-acting beta-2 adrenergic agonist. It enhances, these drugs enhance the action of adrenaline on those little receptors that we saw on the other slide. So let me just get rid of that, and then I can tell you how all of this works. All right then, so let's pretend that your airway is all tight for whatever reason. Okay. When it's all tight, your brain will say, hang on a minute, if that airway stays looking like this, the ability for the respiratory system to do gaseous exchange is going to be reduced. Because if it looks like that, you're going to get less oxygen in, and it's going to be hard for you to get shut of all of that horrible carbon dioxide that can make our blood a little bit acidic, if you like. So at this point, your brain needs to do something about it. And it sends a message, and it needs adrenaline to send that message. And it sends the message to the little beta receptors, and they're on your smooth muscle. And as the adrenaline attaches, the message is relax, and that's what happens. Okay, so that is how the brain relaxes our airways. And now at this point, oxygen can get in and carbon dioxide can get out, and we all live happily ever after. If we go and look at the other side now, the chemical messenger, or the neurotransmitter, for this part of the nervous system is called acetylcholine. Another name for this nervous system is cholinergic, and that's choline there, if you can see. In the olden days, we used to have drugs that were called anticholinergics because they worked against this nervous system. Today, they're called antimuscarinics, and you might see them abbreviated as LAMA, and that would be a long-acting muscarinic antagonist. So an antagonist works against something. So an agonist enhances, and an antagonist works against it. Okay, so just hold that thought. Now then, let's pretend your airways are looking like this, and we're all living happily ever after. However, you come into contact, unbeknownst to you, to a virus. So the last thing that your brain wants is for that virus to get into the alveoli, because it's then only a couple of cells away from getting into your blood system, and then it can very quickly whiz around our body, and before you know it, we're feeling really rough because we've got this virus. So your brain will always want to protect you against things like that. And so what happens is, when activated, the airways can dramatically constrict. So there's that little M receptor, the muscarinic receptor. So your brain detects the virus and it says, right, hang on a minute, we really don't want that virus into our blood system. And it sends its chemical messenger, acetylcholine. And the acetylcholine sticks to the receptor and it tightens everything up. And your brain's thinking, right, now I've tightened all of that up, it's going to make it a lot harder for that virus to get into the alveoli. Okay. And in, let me just take it back one little, let's just go back one, I won't be a second. Oh, I can't go back here. But the drugs that are called antimuscarinics, the way they work is they attach themselves here so that the acetylcholine can't stick. If it can't stick, it can't tell the airways to tighten up. In asthma and COPD, this process is defective. So it's kind of exaggerated, which is why people with COPD, this is exaggerated at the very beginning of the disease. Often this is more in asthma, it's more towards the end of it. And the use of antimuscarinic drugs in asthma are really specialist drugs, because it's nothing wrong with the drug, it's just that asthmatics that get this damage tend to be quite poorly asthmatics. Okay, so that's a little whistle stop on that. When we join everything together, inspiration, breath in plus expiration, breath out, that equals ventilation. And if it's all working perfectly, we'll have perfectly normal lung function. We'll have lovely oxygen saturation, our respiratory rate will be perfect, everything will be just right if we've got normal lung function. But the thing to kind of remember, it's like every organ of our body, like the heart or the brain or the pancreas, kidney, it doesn't matter. If you disrupt the structure, well then you're always going to disrupt the function. You know, if we start off, if our asthmatic gets up in the morning and their airways look like this, and then as the day progresses, they come into contact with the triggers and it goes into spasm, and they can't remove themselves from that trigger, and so we get inflammation, and then they don't get inhaled therapies, then the inflammation and you get smooth muscle hypertrophy, this all enlarges and it can get to the point where you can't fix it. And of course, if your airways look like this, your oxygen levels are not going to be fabulous, and the chances are your lung function, like your peak flow rate or your FEV1, that's going to drop. And you know, so it's the aim of asthma management, you know, is to make sure that your asthmatic's airways look like this. Often when you see an asthmatic, they're either looking like this or this. If, you know, in the severe cases, they do get to the point where it almost becomes, well, not almost, it can become irreversible. This is what happens when you leave asthma untreated for too long. And that's what we're going to look at. In the next video, I'm going to take you through the pathophysiology of allergic asthma. How do airways in asthmatic people, how do they start the morning like this, but then can end up looking like this? So I'll see you in the next video.